and treatment-resistant depression. And I'm going to give something of the background of this difficult topic, looking at its epidemiology and biology. And I'll look a little bit at management, although I'm only going to talk about the broad principles of management. The pharmacology of treatment-resistant depression will be described by a later speaker, Dr. Selick. So just a word about the BAP, the British Association for Psychopharmacology. We are one of the largest psychopharmacology associations in the world, I think second or third, and we're actually quite one of the oldest, and this year we're celebrating our 40th anniversary. So we were formed in 1974, and to promote psychopharmacology, its research and its teaching. The meeting in 2014 promises to be an absolutely excellent meeting. So if any of you can make it to Cambridge, which is a very excellent place for a meeting, then you're more welcome. And we have all sorts of sessions doing both preclinical and clinical psychopharmacology in the same session around one topic. One of the many things that this BAP does is have a continuous professional development, a CPD resource, which is online. And so there's up-to-date talks in all the major areas of psychopharmacology on it. And it's available if you want to try and access it through the BAP website. And I think it's a very excellent resource that gives up-to-date information about how to manage various disorders. So back to treatment-resistant depression. And the first important observation is that depression is very important from a public health point of view, and recently has been described as the West's second biggest killer. So in developed societies, it's the second biggest cause of mortality and morbidity. And this is due to the fact that it goes on for a long time in very many people, the people we'll be talking about today, and causes great distress to them and their families. And it's also associated with considerable mortality through suicide, but also through bringing premature death, principally from cardiovascular causes, although from some other causes too. So, and it's been shown that untreated depression is very much associated with increased mortality and morbidity. And so it's an area where treatment really makes a big difference for people, both in terms of the quality of life, but also the length of their life. Now this is something a little schematic about some of the terms we'll be talking about. So when people move from being normal through symptoms into the syndrome of depression, so we have major depression here, and then during the recovery from that, you move through two phases. First of all, response, which is a 50% improvement, and then you finally move into remission. And of course, once you reach remission, you're prone to have relapse or recurrences. Relapse if they occur soon, and recurrences if they occur a bit later. But of course, that's the ideal outcome shown here. But many patients develop long-standing depression going on for many years and become chronic. Others develop only an ill-sustained response, often a sort of placebo response. Others just partial remission, and they never get fully well, and those are very high-risk patients. And others have an unstable response. So what are the numbers around this? Well, we know depression is very common, but we also know that treatment-resistant depression is unfortunately very common. So approximately 30% or 30 to 40% of patients fail to respond to their first treatment for depression. In this case, probably talking about a single antidepressant. About 1 in 3 fail with that. If you define treatment-resistant depression as failing 2 or more agents, and also other things you might do, then it becomes much more common. And about 20% of patients fall into this category. And finally, unfortunately, there's a category of about 10% of patients who develop a chronic refractory depression with non-response to multiple treatments, including ECT, and lasting for longer than 2 years. So it's a very common disorder, given how common depression is. And this outcome has been shown in all sorts of different societies and communities, and also in primary care and secondary care. So it seems to be part of the natural history of the disorder to have these patients with poor outcomes, somewhere between 10 and 20% of patients with a pretty poor outcome. So currently available antidepressant treatments are effective only in 50 to 70% of patients, and about 20 to 30% of patients have treatment-resistant depression. And much of this overall suffering and burden we see from depression is due to the patients who are in this category of treatment-resistant depression. And it's a concept which is complicated. It refers to not responding to treatment, but it's tied up with chronicity, residual symptoms, and relapse and recurrence. And it's a very complicated phenotype with all sorts of different sorts to it, but that's a broad picture of it, as we see here. Those patients who have more frequent recurrences are very much likely to fall into this category of eventually having treatment-resistant depression. So what happens to these patients? Well, a follow-up study has been done looking at a meta-analysis of all the studies, and we know that these patients do badly. 80% of those requiring multiple treatments relapse within a year of achieving remission. And so it's got a poor outcome, and it's also got a poor long-term outcome. And for those who've got a very complicated illness, the probability of recovery within 10 years is only about 40%. So it's a disorder that once one's got it, it does lead to long-standing morbidity and problems. So it's important to try and treat it and manage it and recognise it as early as possible and get effective treatment as early as possible in the condition. So who of our depressed patients is likely to get treatment-resistant depression? Well, there are various clinical subtypes, for example, those with atypical depression or psychotic depression or bipolar depression, where that's not been recognised, are likely to become treatment-resistant. Those patients who take substances and those patients who are associated with anxiety disorders are also very common. Now, there is an issue around personality, and previously it was thought a lot of these patients had personality disorders, but we know that now not to be true, but a lot of them have personality traits that lead, or certainly are associated with poor outcome, and I'll come back to that in a moment. And it's also associated with longer-term physical illnesses. Of course, it's worse in those people who don't adhere to medication or who have a delay in treatment. And finally, it's found in those people who have an early age of onset. Females are more common with treatment-resistant depression than males, much more common, and it's associated with lower socioeconomic status and a non-supportive environment, and I'll touch a little bit on that in a moment. So it's a classical area of psychiatry which has biological components to treatment resistance, and it also has psychological and social characteristics associated with this problem. This is some data we've recently obtained from a very large number, 165 patients with depression, with treatment-resistant depression, who'd failed to respond to at least 2 antidepressants. And here we're looking at the problem that patients like that tend to ruminate. And they ruminate very frequently more than healthy controls, which are shown in red. They brood a lot, and they have depressive-related brooding particularly marked, and this is very highly significant. And we think this phenomenon of brooding is a mechanism whereby social problems and psychological problems lead on to long-standing depression. It seems to be the pathway along which the depressive problem seems to extend and get worse. If you look into the background of many of these patients, many of them have had very difficult upbringings, and this is a rating scale looking at childhood trauma. And many of these patients have trauma of one sort or another, physical or emotional, during childhood. And emotional neglect, being neglected by your parents and not thought of in a caring kind of way, seems to be a very strong component. And if you look at the associations between brooding and childhood trauma, they predict a tremendous amount of the variance in a depressive population. And we know that childhood maltreatment is a very important factor when it comes to outcome. And it's called here a simple predictor. And what that means is that it affects every possible treatment you might want to give. And here's some data in adolescents, here's some data in adults with antidepressants, and here's some data with psychotherapy. And in all of these cases, those people who had been maltreated in childhood did worse than those people who hadn't. So it seems to be a very powerful predictor of poor outcome and seems to affect all classes of treatment. And we know the converse is true. This is some data from the Institute of Psychiatry showing that if you follow up patients with treatment-resistant depression, the ones who do best are those who have strong family support in terms of staying well, but those people who have only moderate or weak family support tend to relapse quite quickly. So the environment and the psychological environment of the patient is crucial towards the outcome. And having recognised this, it's our duty to do something about that. And I'll talk about the psychotherapy of the condition a little bit later. Now, what about the biology? Well, there are various possibilities of what might make those patients more prone to depression and more prone to poor outcome. And Brian Leonard, our next speaker, will talk about one particular area to do with inflammation in a moment. I'm going to talk about two areas that have recently attracted interest. These are the fact that cortisol secretion seems to be abnormal, more abnormal in these patients, and secondly, that there's problems with the white matter in the brain. So first of all, looking at the steroid effects, this is the well-known stress hypothalamic pituitary adrenal axis producing high levels of steroids. And most, of course, we know everybody when they get stressed has high levels of cortisol, which then fall. But that fall doesn't seem to occur in those with long-standing psychosocial stress or those with depression. Now, we know that your propensity for getting long-standing problems with high levels of cortisol and dysregulated cortisol is something that does, again, depend on your childhood environment. And here's some data looking at genes and gene expression. And these two genes that we're looking at here are important in controlling the hypothalamic pituitary axis. And they become dysregulated through epigenetic mechanisms with separation events in childhood, with trauma events in childhood, and severe trauma, in each case causing a dysregulation of the axis, particularly in those who are vulnerable. So there's an association here between what seems to predict poor outcome depression and the hypothalamic pituitary axis, perhaps through a genetic mechanism. Now, how does one test this axis? Well, one of the more exciting ways of doing that is using prednisolone as a test rather than dexamethasone, because it affects all parts of the axis. And the axis is controlled by MR receptors, mineralocorticoid receptors, and GR receptors, glucocorticoid receptors. So if you give prednisolone, you get a better view of how the axis is performing. And here's some data from the Institute of Psychiatry again, showing that patients with depression are actually similar to controls, but those patients with treatment-resistant depression are abnormal. They have abnormally elevated levels in response to prednisolone. They don't suppress as much with prednisolone. So there seems to be this link between poor outcome and steroids. So cortisol is elevated in some patients with depression, particularly those with poor outcome and severe illnesses, and this may be due to genetic and gene environment interactions causing some of those problems. So does this matter? Does it matter that cortisol is dysregulated, or perhaps it's just an innocent bystander? Well, there is evidence, and this is some from our laboratory in Newcastle, to show that if you have high levels of cortisol, then antidepressant drugs work less well. And what they've done here, Sasha Gartside in our laboratory, has given fluoxetine to rats and looked at forebrain 5-HT, which is probably how the drug works. And so you get a big elevation of 5-HT in the forebrain after fluoxetine in the normal situation. But if the animals have higher cortisone levels or dysregulated cortisone, then that increase is not seen. And one of the important things about this is that this can be blocked. And if you give a drug which blocks glucocorticoid receptors and give this to animals, then this is again given fluoxetine. The animal produces high levels of 5-HT in the forebrain. And if they're given the drug which blocks cortisol, or blocks the access of cortisol to the brain, the increase in 5-HT is even larger. So this suggests that that steroids might be part of the reason why patients do badly. And we know that, in fact, there is a relationship between high levels of steroids and poor response to antidepressants. And this seems to be the biological mechanism of that. So the fact that one can block this with GR receptors led us to ask the question, if we give a GR receptor to patients with depression, will it produce better outcomes? And so what we did was a study where we gave the drug methylphystrone, or RU486, which blocks GR receptors selectively in the brain. And we gave this in a study where we gave half the patients methylphystrone in addition to antidepressants and half of them placebo. And here is the depression scores in this study. And this results with methylphystrone, which looks very exciting until one looks at placebo and discovers that placebo is exactly the same. So for some reason, there doesn't seem to be a benefit in terms of mood in adding methylphystrone or blocking the GR receptors. This might be due to dose, because other studies using higher doses of this drug have produced clinical benefits in terms of depression scores. But what we did find using this paradigm, using the GR receptor, was that cognition improved, memory and learning improved, and this is spatial working memory. And in blue here are patients several weeks after the GR receptor with improved, less errors on their memory test, looking at particularly spatial working memory. And this is the second or third time we've done this, showing that